All right, I think we're ready to get started, so I'll try not to ramble on too often and keep everyone over the allotted time on a Friday afternoon. But I wanted to talk today a bit about what I kind of see, and one of my, I guess, hobbies, if you will, within the profession is I'm fairly interested in drug policy, and particularly some of the debates surrounding the cost of medications throughout the spectrum of healthcare. So I'm going to talk about at least some of the changes within the cardiovascular arena, which I think to date has largely been fairly immune to this, but we're starting to see more and more therapy. So in a way, it's a little bit of a new drug update with some of the bigger changes as far as novel pharmacotherapy within the cardiovascular setting. But also a way for me to stand on a soapbox up here and rant about what I see as some of the pricing structural issues within this setting. And so we're going to talk about some of these emerging cardiovascular therapies, which are, I think, beneficial in terms of reducing cardiovascular risk, but are very incremental, I think, in the way that they do so. And even in cases where we have significant improvements in terms of outcomes, the pricing structure has not kind of lend itself particularly well to adaptations. I'll talk about one example later in the presentation, and then just look at what the cost effectiveness really is with some of these therapeutic advances. I won't talk too much about what we actually do with patients, and because a lot of these therapies are novel enough that paradigm hasn't really been developed. But I did want to segue and talk a little bit about just nationally kind of what some of the policies and issues are surrounding drug pricing and the effect it has on patients. So I wanted to start by making fun of oncology because I like to do that within presentations. So thanks, Kevin, for staying and representing. But no, I did want to draw everyone's attention. I think this has hit the news quite a bit, and I've been interested in watching CAR-T gene therapies as well. You guys may have seen that we treated a patient here, and it made the UVA connect, and everyone's very proud of that. But no one really is talking about, I think, or a lot of people within the care delivery setting are talking about the exorbitant costs that they're extracting out of the system for this therapy. And I'll talk a little bit later why this is even, I think, more of a tragedy, because Novartis didn't really actually even develop this drug. It was really publicly funded. But CAR-T therapies, so for particular leukemia, is another, I guess, more and more potential cancers, which really is an advance in a lot of cases. The cost is coming in really almost a $500,000 mark, and even then, when you see if you peek within the pharmaceutical world, they even attribute this to being a bargain based on what they could have extracted out of it, which I guess makes us feel better. But within the cardiovascular setting, we're really seeing the point of diminishing returns, I think, for a lot of cardiovascular diseases. It still remains the leading cause of death within the United States, so I don't want to throw all the flashy statistics up. Sometimes oncology beats us out for a year, but then we take it back the next year. So virtually everybody's affected by cardiovascular disease, and so I like to play that game with students where somebody will come in and be like, oh, what has everyone ever heard of somebody who's had lung cancer? And you see some hands go up, but virtually you see cardiovascular disease, everybody has been affected in some way, shape, or form, or know somebody that's suffered through it. And so really the advancements in the field with risk reduction has really been accomplished through what we see as modifiable risk factors. So the large health campaigns around treatment of blood pressure, smoking cessation, diet and exercise, so all these things that contribute to risk reduction within cardiovascular disease has been what we have traditionally worked on. The non-modifiable risk factors, when we target them with pharmacotherapy, have really been hit or miss in terms of their benefit to the patients. And so we've really hit upon statins, which really has been, I think, the largest singular change in terms of pharmacotherapy that has actually moved the needle in terms of risk reduction. And we've explored statins in hundreds of thousands of patient clinical trials and over dozens of years. But there are other things that we have seen as observational associations. So, for example, HDL increasing therapies. You guys may have seen antroceptrapib and torcetrapib have really been not moved forward with the development. There was a press release yesterday that Merck was dropping the last development of one of the last therapies in this setting. And so really increasing HDL, despite the environmental and observational correlation, has not been shown to be of significant benefit. So in a way, we've had kind of mixed success with this, with looking at non-modifiable risk factors as drug therapy targets. And so I'll spend a little while to talk about what the next advance has been or is continuing to be with cholesterol, which is really continuing to look at optimization. But as you'll see, we're starting to see diminishing returns with that. And so we have known for decades that total cholesterol is associated with CHD risk. And so these are just two large studies. Everybody, I think, is fairly aware of the Framingham study, which is a huge observational cohort study of Massachusetts town. And then there's the Mr. Fit trial. We have the best names in our cardiology trials. It's one of my personal favorites. But you can see that very clearly associated with, over time, the higher the total cholesterol, and you could put LDL up here as a correlate as well, that significantly correlates to the risk, whether it's 6-year or mortality or CHD incidence. And so this association has been known for a long time. And we have used statins to really validate the fact that lowering cholesterol is associated with better risk outcomes. And so we have, I think, started, and some of you maybe have been around or have heard of the 4S trial and WASCOPS and a lot of these prevention studies that really are the ones that set this field up for reducing risk and proving the concept that lower LDL is better. And then there started to be a little bit of doubt about this in that we've seen such benefit associated with statin therapy. There was a real, I think, moral moment where we were thinking maybe it's just the statin and not the LDL itself, but you can actually see, I think, through some of the more recent data that still is, I think, fairly validated that LDL and the association with outcomes as a treatment target is still beneficial. But what you can kind of see here is there's a tremendous drop in the beginning, and I think over time you see as we get to sort of the bottom of this curve that the benefit to the patient is leveling out some. Despite that, what we think of is completely eradicating LDL, and I'll just show you some of the targets that we're reaching with contemporary therapies. We still have not yet eliminated cardiovascular disease, and that's sort of a tongue-in-cheek comment, but you can see despite the improvements in what we see as one of the primary drivable risk factors, which is LDL cholesterol, we have only the beginning, I think, of risk reduction for these patients. And so there's still, and these aren't including some of the most contemporary papers, but there's still about 60 to 80% of residual risk despite optimal treatment within this. And so it's led us to search for other ways to think about risk for patients and reducing them. And so one of those is going to be the PCSK9 inhibitors, which are a non-statin, very effective way to reduce LDL cholesterol. And so these are two drugs that have been developed in this setting with a third on the way. So this is alirocumab and evolocumab, which are every 2 weeks sub-Q injections. And these are monoclonal antibodies for and this is the last time I'll say this, the proprotein convertase subtilisin kexin type 9 PCSK9 receptor. And PCSK9 is a very central process, and I have a very small cartoon that nobody can read in the bottom in the corner. But basically all you have to pay attention to is on the left side of this is the liver, and essentially the PCSK9 receptor in the liver is responsible for LDL degradation. So inhibiting that results in very significant reductions in LDL cholesterol, really beyond what we see with reducing or inhibiting HMG-CoA reductase. And so really these drugs were developed for an orphan indication originally. So there are patients out there with genetic predispositions for hypercholesterolemia that we call familial hypercholesterolemia, or FH. And so patients who are homozygotes for this disorder have incredibly high cholesterol levels and have incredible morbidity related to cardiovascular disease. So people who develop, triple artery disease within coronary disease in their 30s or even later. And then there are even patients who are heterozygote, so only have one gene passed down, that also are at significant risk. And so this has been of interest for a little bit of time. So you can see this paper goes back to 2006, but we were very excited for the prospect of PCSK9s in reducing cardiovascular outcomes. And so this is a genetic study. And so since we have all this genetic data, it's really kind of a clever way to look at whether we think a drug will be beneficial or not. And so this is a graph looking, and this is data from the ERIC study, which is essentially like Framingham as an observational study that took place over 15 years, but looked at a lot of different ethnic varieties as compared to Framingham, which is very much kind of a Caucasian dominant study. And so in this sub-study of this was all African American patients, and they looked at patients who had developed, and these researchers identified 2 PCSK9 genes that were actually nonsense genes, meaning that they essentially resulted in knockout of that gene for the patient. So it's like they were on a genetic PCSK9 inhibitor. And so they showed in this top graph is patients who had the regular PCSK9 that was functional had a very normal distribution of LDL cholesterol levels. And so the median in this trial was about 130. So it's about very similar to what we see in the U.S. average population. But patients who actually had a knockout, so patients who had nonsense mutations, had significantly lower plasma LDL concentrations. And so you can see in this study, this is only in 85 patients, but the median was probably somewhere around 70. And then when you look at what this did in terms of cardiovascular disease over a 15-year follow-up, patients who had PCSK9 knockout basically didn't have cardiovascular disease versus those who didn't essentially have what we see as the normal proportion. So this is kind of very interesting in terms of, and very valuable in terms of informing us whether a drug would be beneficial or not. And so the PCSK9 inhibitors, the drugs themselves, are very effective at reducing LDL cholesterol. And just to give you a preview, so I did my Who's Well screening this morning, and so I'm probably up here on this red line, about 120 or so, and trickling along, and that's probably about what we see in terms of the U.S. average. We have different levels of treatment goals for patients, of course, with different levels of risk. But just giving someone like me, who doesn't, at least as far as I know, have cholesterol or coronary artery disease, a PCSK9 inhibitor results in very substantial reductions. So patients in this, at least proof of concept study, had reductions down to median LDLs of around 40. So that's very significant in terms of reduction, and probably a lot more efficacious than most any statin therapy has been able to offer. So this is about 61% reduction in terms of the LDL, and really with a fairly substantial safety profile that isn't too harmful in terms of the effects that are caused. So really no LFT changes or muscle toxicities, which has been one of the real limiting issues with statins. And because they're monoclonal antibodies and rabbit-derived, there are concerns for allergies, but are really very well tolerated medications. And so the outcomes data with these, we'll talk about FOURIER in a second, which has been the major trial published to date with evolocumab. Alirocumab still has an outcome study that will be published, and I have it. When these trials first were announced, I was sort of cringing with where pharma was really taking this market, in that they're trying to really go for what they see as the biggest, I think, population to treat, which is patients who are already on statins and placebo and high risk of recurrent cardiovascular events, to give them PCSK9 on top of those therapies. Whereas the value I always felt, I think, with this is the patient populations who are statin intolerant. So groups that we have trouble treating, groups that have trouble getting access or tolerating statins, I think would have been a little bit easier proof of concept. But they are going for really the very largest market out of the gate. And in terms of the pricing structure for these, so intrinsically when you hear about monoclonal antibodies, you associate that with manufacturing costs. But really, these are fairly expensive, especially when you think about it compared to what we see as generic atorvastatin or generic rosuvastatin. So about $25,000 per year was the pricing structure for these out of the gate. And so the FDA was okay with initial approval even before there were outcomes studies, just based on the indication for FH patients. But they also included patients who had cardiovascular risk and were statin intolerant or required additional LDL lowering, despite the fact that there weren't really outcomes data for that. And so there's already a lot of, I guess, navel-gazing about whether these would be the price or the drug that would break the bank, so to speak. Because when you think about the patient population for an orphan drug or even FH, you're talking about a fairly small patient population. But when you think about the people who are at high risk of cardiovascular events who are already on statins, you're talking about millions and millions of people. And so when you price a drug $25,000 a year with the market that large, you're really talking about some substantial cost to the system. And so FOURIER, which is published last year and presented at the ACC meeting last year, was a 27,000 patient trial looking at patients who had established cardiovascular disease, so those with prior MI, stroke, or symptomatic peripheral arterial disease. And these were patients, I will point out, are already on higher moderate intensity statin, which could include ezetimibe as well, and had to have an LDL of greater than 70 or a non-HDL of greater than 100. So these would be people that we perceive as having residual cholesterol risk. And so they were randomized to evolocumab versus placebo and were followed up every 12 weeks. And so, again, these are the LDL measurements. Patients in this trial were driven down to a median LDL of 30, which is incredibly low when you think about what the normal population walks around with. So this is a very significant reduction on top of what was already not really too bad in terms of an LDL treatment goal. The endpoint, so it actually was a positive trial. We got this press release before the results were presented that it met its primary endpoint, which means that the trial would be positive in some way, shape, or form. And so we did see a reduction in the composite endpoint here, which was cardiovascular death, MI, or stroke of 7.9 versus 9.9. Has a ratio of 0.8, and unfortunately this didn't translate to death, so this was an endpoint that was really driven by reductions, at least statistically, in stroke and MI, but no mortality difference, which does make a difference, I think, when you go to payers in the system to talk about your pricing structure. But undeterred, they proceeded, I think, with this data in hand, and when you actually run the numbers on this is sort of back of the napkin math here by myself, but if you look at the number needed to treat within this trial population and look at how much money the system is spending to prevent an event, this is about $2.4 million to prevent one myocardial infarction, or $7.5 million to prevent one stroke, which is really quite significant. And so there were a lot of comments that, and I think ways that industry is thinking about pricing models. And so one of the things that they came up with was the preventative effect of an MI or stroke. Could we rebate a company if a patient receiving this medication had an event? And so you say, well, we have this MI or stroke, we're going to rebate you this amount of money back to it. And so that sounds like very attractive. But unfortunately, when you look at what that means in terms of costs, since the number of events were actually quite low in this study, it only amounts to about 5% of the annualized drug costs. So it really is a quote-unquote drop in the bucket compared to the money extracted back out of the payers in the patient population. When you look at what the cost-effectiveness threshold actually is, so what probably the price should be, if you look at rational differences in terms of quality-adjusted life year, it probably should cost around $4,000 a year based on the outcomes seen in 4 year, which would be about $300 a month. And that would be about 70% of what the drug currently costs. So it's, or 70% price production. So about 30% of what the drug actually currently costs. So there's a lot of work to be done here. And so there are still attempts, I think, to try to figure this out without reducing cost. But the bottom line is, for anyone who's trying to obtain these therapies for patients, it is virtually impossible to get somebody on one of these medications, even when they have legitimate indications and needs. And so this was a publication actually at the same ACC meeting. And so I talked to this author at a different venue and was aware of the study, which I think is really interesting. But they had done a study looking at out of Duke, looking at patients that they provided prescriptions for PCSK9 inhibitors. And so, with these battles between payers and manufacturers, the payers are more than happy to say, like, okay, we will put your drug on formulary, but we will make it tier 3, or we will require 50% copayment from patients, or we will require so much prior authorization that somebody gives up along the way. But what many payers are taking in terms of the thought with this is to require a large coinsurance payment from patients. And so this basically results in the patient coming to the pharmacy, getting a bill for multi-hundred, if not $1,000 in terms of copayment, and then actually leaving the prescription at the pharmacy. So even if you're able to get through the system in terms of getting this approval, 1 in 3 of these actually are never even picked up from the pharmacy, and that's probably due to coinsurance costs. And so this leads us to our first self-assessment questions of which of the following is true regarding PCSK9 inhibitors. So A, they decrease the inflammatory burden and improve cardiovascular outcomes. B, they decrease LDL but are inferior to statin therapy. C, they decrease LDL and improve cardiovascular outcomes in addition to statin. And D, they're substantially cost-effective with the current pricing structure. Now, I worked on this animation myself, and I'm really proud of that. So C, for those of you who are I came up with that. And so I wanted to switch gears a little bit and continue to talk about this concept of residual risk. And so this is actually a very new and in some ways old paradigm for the treatment of cardiovascular disease. And so I alluded to the fact that we were concerned or very preoccupied, I would say at one point, with there being something special about statins. And so we know that the underlying pathophysiology of acute coronary syndrome isn't just risk factor based. So there's probably also something inflammatory going on and something that leads to development of unstabilization or destabilization of coronary plaque. Because as I tell a lot of people that come on rotation with me or just work with me, if you go around doing coronary angiograms of virtually every elderly patient, you'll see coronary disease, but there's a difference between people who develop unstable disease versus not. And so inflammation has always been one of those very attractive puzzles that hasn't been quite figured out, but we have, I think, a lot of new information about this and some proof of concept. And so we knew that this was an issue, and I'll show you some of the background data leading up to this. I'll talk about Jupiter in a second, but high-intensity statin therapy has already been shown in concert with an elevated C-reactive protein to be beneficial in terms of cardiovascular outcomes. And we know that inflammatory biomarkers have been shown to really predict development of cardiovascular disease. So there are observational associations of high sensitivity CRP or interleukin-6. So all these things have been shown to really correlate with risk. And so we got this press release. To me, it was a little bit out of the blue because I wasn't tracking this area intently, but we got this Novartis press release that ACZ885 or canakinumab reduces cardiovascular risk in patients who survived a heart attack. And so this, I wasn't aware they were doing this trial, but this was looking at this agent as an anti-inflammatory agent, and they actually had a positive outcomes-based study, which, again, I think they sort of swung for the fences and developed this drug really going for an outcomes-based study. And usually you have some lead-up into that happening. But this is the way they sort of perceive this. And so we know, again, we have this puzzle. I've already introduced the fact that we have this known cardiovascular disease. We put patients on high-intensity statins, and we have this residual cholesterol risk. So patients who have LDLs, at least if you think back to 4 year of 90 or above or 110 and above, don't have inflammatory burden. And so we consider additional LDL reduction for those. I haven't talked about the Improve It trial, but there's also benefit to ezetimibe in this setting or PCSK9 inhibitors. But there also is the same patient, and particularly patients who have well-controlled cholesterol that still have events. And so we can look at things like C-reactive proteins and look at inflammatory reduction, and we've never really shown in a prospective clinical trial that that's a benefit. And so we had some clues that this was the case. So this is retrospective data from the Prove It trial, which was over a decade ago at this point, which looked at recurrent MI or coronary death and divided it into quintiles or quartiles of whether the patients achieved an LDL goal or whether they achieved a CRP reduction goal. And what you can see here is that patients who achieved both an LDL and a CRP goal had the lowest risk, but patients, whether or not they achieved a LDL cholesterol goal, if they had inflammatory risk or if they had cholesterol risk, those appeared to be kind of independent risk factors within this trial. So again, we've known this for a while. The previous trial, which was Jupiter, actually had CRP as an enrollment criteria. You can see here that patients had to have a C-reactive protein of at least 2 to get into this trial, and looked at, I guess, what you would call an intermediate risk patient population randomized rosuvastatin versus placebo. And again, the problem with this, though, is that we didn't have a group that had a normalized CRP to know within this trial how significant the inflammatory inclusion criteria was. And so the outcomes associated with this was a 44% relative reduction with the number needed to treat of 25. One thing I've really appreciated in the newest New England Journal articles is I've gotten really irritated with y-axis inflation. You can see here that this starts at 0.00 and goes to 0.08. So they're showing literally an 8% spread out of 100. So this is like, in the newest New England Journal, they actually show you the full 100% thing in the bottom corner now, which has really made me happy because this kind of thing I think is leads to everybody, I think, sort of over-contextualizing results in clinical trials. So we have this benefit, but you could also argue that maybe this is just a population benefit for rosuvastatin in intermediate risk patient populations. And so we still have not really known, I think, definitively this inflammatory concept. And so to give you an idea for what canakinumab is, so there's an interleukin-1 beta, an antibody against interleukin-1 beta. And so the theory with this is that within a coronary plaque is you have an inflammasome, which is NLRP3 is at least the one that's identified in this pictorial. And there are a number of events that activate this inflammasome, and so it could be cholesterol crystals, it could be atheropoietin flow, it could be that there are extracellular traps that entrap neutrophils or hypoxia, so things that are like, think about ischemia. And so those things activate the inflammasome, which contributes to the production of interleukin-1 beta. And interleukin-1 beta has been associated in a lot of translational models. This is truly, I think, one of the first real translational science victories within cardiovascular medicine, at least in the modern era, where you've seen a lot of really good models develop where they've looked at this in a number of different settings. And so for those of you who are familiar with VCU, they have a really good model over there where they've looked at interleukin inhibition and a lot of translational science related to that. They actually are not looking at canakinumab, they're looking at a receptor antagonist, so anakinra, which is used for rheumatoid arthritis. And then there are also other compounds that are in development, so there are fake interleukin-1 beta receptors, so like traps that are being developed as well. And so there's kind of a lot of activity in this area. But there's been a lot of translational science which has established the proof of concept for why this would work. And to their credit, they really funded a very large and expensive outcome study when potentially they could have done something a little bit more conservative. And so this was the CANTOS trial, which was presented a few weeks ago at the European Society of Cardiology, but it looked at patients really who were stable coronary disease, so not post-ACS patients per se, but really somebody with the stable CAD with prior MI. Again, on statins, so things that we know to do, but also looking at people who had residual risk with elevated C-reactive protein. And so they randomized to a couple different doses of canakinumab and looked at primary cardiovascular events, which was non-fatal MI, stroke, or cardiovascular death. And so this is just surrogate markers, which may be a little bit difficult to see, but this is sort of just, again, beating you over the head that these are not anti-cholesterol drugs, so that you can see that nothing changed in terms of lipids in this trial. So total cholesterol, HDL, and triglycerides are all basically the same. But what really did change was the reduction in CRP. So in the highest canakinumab dose, there was up to a 70% reduction from baseline. And so in terms of cardiovascular events, we already knew that this trial would be positive. So this is the degree of positivity. Again, watch the y-axis inflation, but at least we get up to 25 on this one. But there was a reduction. If you look at the combined canakinumab groups, it has a ratio of about 0.85 with a significant p-value. Again, no change in LDL cholesterol. It's about a 15% reduction from the placebo group. And to look a little bit more at this, because I think there's some kind of interesting details in here, one of which is we know the primary event's positive. The secondary event just rolled in urgent revascularizations. But you can see, again, sort of like PCSK9 inhibitors, there really isn't any reduction in terms of cardiovascular death, so that wasn't actually significantly reduced, nor was all-cause mortality. So this is really talking about non-fatal MI and possibly stroke reductions if you draw that out a little bit more. And further, we know that I think making any modifications to the body's immune system is associated with some risk with it. And so there are risks of adverse effects, particularly leukopenia within this. And so where interleukins came from is these are one of the primary drivers for things that occur when you're sick. So things that are prodromes like fevers, and a lot of the inflammatory reactions that occur are around interleukins, and so it's not really surprising, and I think was expected to see leukopenia develop within this trial. But also fetal infection was increased, and one of the really interesting things that we had to talk a few weeks ago, I wasn't aware that it really wasn't opportunistic infections that were increased. What really appeared to be increased was the fact that if you had an infection, your body could not respond to it. So it basically just amplified the effects of an existing infection. So it's not like you got PCP or some opportunistic infection that you wouldn't otherwise get. It's the fact that it basically took down your body's defenses in terms of inflammation to be able to fight an infection. So it really just amplified what was already there. The other thing is that fatal malignancy was actually significantly reduced. So Kevin, thanks for staying for this, because this is where we'll talk about some oncology again, but this actually does appear, they were a little worried about this contributing to cancer development, so they were watching it very closely, and I'll talk a little bit more about it in a second, but malignancy actually was reduced fairly significantly. And then other inflammatory disorders, so think about like gout, arthritis, so these things were also reduced with canakinumab, so things that are inflammatory. And so I wanted to talk a little bit just for anybody who's interested in the room. It was really actually lung cancer in this trial that was reduced with canakinumab, and they showed this both with the incidence of lung cancer, and I don't have the slide here, but also mortality related to lung cancer. And so feel free, I think I'm sure they're going to be looking at this and looking at adding anti-inflammatory therapy, which I think you wouldn't intrinsically think about as a positive thing for cancer. So it's something I'm certain that they'll be exploring in terms of drug development. So the question really is this cost effective? And so canakinumab is actually already approved, and it's approved for things like cyropyrin-associated periodic syndromes, familial Mediterranean fever, and then there's another list of things that I really didn't know and didn't want to bother to type out. So HIDS, MKD, and TRAPS. So anybody who knows what those things are, canakinumab is your drug. But it is very much priced in terms of orphan drug costs, so it's about $20,000 per syringe, and so if you extrapolate that out within this trial, that's about $80,000 per year for these patients. So again, just back of the napkin math, if you do number needed to treat for the major adverse cardiovascular events using the 150 dose, that's about 156 patients treated to prevent one event. And so that's about $2.5 million for one adverse cardiovascular event, and a little bit more favorable if you talk just about myocardial infarction. Again, no impact on death, and there is, of course, a number needed to harm because of fatal infection, which is about 769. And so this is a wonderful proof of concept. It is in no way, shape, or form, I think, remotely cost-effective under this pricing structure. And so I've never seen the editorial that appears in New England Journal when there's something like exciting and new. And this was literally the last paragraph of it that was written by Bob Harrington, who's came out of Duke and is now dean at Stanford. But basically said that this has helped move the hypothesis forward. However, this is modest clinical benefit, and they can't really justify the routine use of this therapy until a price restructuring and formal cost effectiveness evaluation supported. So that's like fairly slap down as far as you get your initial publication in New England Journal, and then somebody's on the editorial is kind of yeah, we don't know about this. And so there is, I think, just because this does prove the concept more, a lot of other things. So inflammation is a lot of different targets, and so there's actually an NIH funded study looking at low dose methotrexate in similar patient population, and of course there's a lot of potential for competition here. I mentioned anakinra, which is an IL-1 antagonist, and then rilonacept, which is an IL-1 trap, are all in development. And at least if this pathway is correct, I think those probably all have similar outcomes in terms of benefit. And so the barrier with this is really, also that it's the biologics, and all of these drugs are biologics. And so there's, to date, with the way reform has gone within pricing structure, there hasn't really been, I think, enough movement to reform payment pathways in this setting to make it the cost come down significantly. And so self-assessment question number 2. So interleukin-1 beta inhibition has been shown in high-risk cardiovascular patients to reduce all of the following except A, recurrent myocardial infarction, B, fatal infection, C, cancer, or D, C-reactive protein. B. That's let me see it again. All right. Fatal infection. So I wanted to shift gears a little bit and give one more example, and this is, I think we're talking about new paradigms, new treatment strategies, and things that are kind of breaking the mold in a lot of ways. But I wanted to talk about one more advancement and just complain about the cost of routine business, I would say, and something that was really, I think, disappointing based on how beneficial it appeared to be in clinical trials. And so this is the area of heart failure, for which industry has been trying to break heart failure for over a decade at this point. And so since I trained, there hasn't really been anything new that has happened, which I've enjoyed greatly because I was really tired when I started my career trying to find the beta blocker du jour of the month, and some way for a patient to receive this recommended beta blocker that costs a whole lot of money for them. And so we've had kind of this, I guess, holy trinity, if you will, of ACE inhibitors, beta blockers, and aldosterone inhibitors that have all been shown to decrease mortality in virtually all phases of symptomatic heart failure that we've known about. But that's been sort of the case since the early 2000s. And there have been a lot of developmental failures from industry. And so some of you may know that vasopressin antagonists were actually, so your tolvaptans and conivaptans were actually developed as heart failure therapies. And so the sodium thing we knew kind of on the side, but they really were brought to market in an attempt to improve cardiovascular outcomes in heart failure, and were not able to do so. And so those were disappointing. ARBs plus ACEs have largely not been all that exciting in terms of benefit. The renin inhibitors with allosterin was an amazing failure in a lot of different cardiovascular settings, and is, I think, barely still on the market. Levosimendan and nasiratide, I could do an entire grand rounds about probably each of these, in that they were thought to be of import and then used very widely in nasiratide's case, and not actually shown to do anything in terms of outcomes for the patient. And so we're all very excited to hear about angiotensin neprilysin inhibitors, which the field has called ARNIs, because the angiotensin receptor neprilysin inhibitor. And that does kind of roll off the tongue very well, but this is looking specifically at valsartan, sacubitril, or Entresto, which some of you may have heard of. And so the concept with this is, of course, we know what valsartan is. That's an angiotensin receptor blocker, which we've had available for some time. But sacubitril is actually the neprilysin inhibitor, and the theory behind this is that you have endogenous vasoactive peptides of a variety of different stripes, but all these have been actually associated with counter-regulatory benefit in heart failure. And so natriuretic peptides, bradykinin, all these things actually do good things for heart failure. So they decrease neurohormonal activation, they improve vascular tone, decrease sodium retention. And so neprilysin is actually a substance or an enzyme that degrades these vasoactive peptides. And so combining this neprilysin inhibitor, which is really the only new piece of this molecule, with valsartan could actually be a benefit. And so they developed the Paradigm HF study, which was really a couple years ago now, 2014, and we're able to show some fairly substantial reductions in terms of cardiovascular death. So the primary endpoint was death or hospitalization, but both of these endpoints were significantly reduced without combining them in a composite. And I would literally just crib this from the paper, because I think it was a little bit of spiking the football to put the p-value, like decimal place, out to like some exotic reduction. So they have a number of zeros here, and so I don't know if somebody committed a typo, because this isn't safe looking at this if we had to program that or make anything. But anyway, and so Paradigm is actually beneficial in terms of improving cardiovascular death. I won't get into some of the discussion around it. I think there was some concern. This is really comparing it to an ACE inhibitor, which I'll also point out is the first time there's ever been an ARB compared strictly to just an ACE inhibitor-based regimen. But there are also some questions about the methodology, and the ACE inhibitor dose that was chosen it's somewhat on the moderate end. So it's not, I think, completely clear that within the trial conduct that it would be as beneficial as it appears to be, but being that as it may, it is, I think, fairly beneficial in terms of the outcomes, but there are a few more things to consider in terms of side effects. So one of which is it results in more hypotension, and that's probably because you're increasing the bioavailability of endogenous peptides. And so we have that concern, and probably don't routinely use it in the hospital setting because this trial was really done in very stable heart failure patients. And so we're still at a little bit of arm's length with it. It does result in less hyperkalemia and less renal dysfunction compared to ACEs, and of course the cough would be less because it doesn't have the ACE inhibitor component. And so really it is probably better tolerated if you would just sort of read the byline here compared to an ACE inhibitor with a significant reduction. And so that was put out in 2014. It was very easily approved by the FDA, and there was a lot of excitement and interest in this. And then it's come out, and we haven't really used it. And I'll talk about why in a little bit more. And so this has led to a lot of headlines like, "What's wrong with Entresto?" Or "What's wrong with why is this drug not selling?" And there's even been these publications that have shown, well, it's being sold in Europe. So we have these nice sales curves in Europe where we've had a lot of excellent movement. And then it's led to even Novartis having to go to their shareholders and say, well, it's slower than we expected. We're working on access and all these things, and a lot of like kind of these slow start headlines. And so I did want to talk about some of the reasons behind that, which of course comes down to cost in some ways, but there's a little bit more to it in that if you think about ACEs, I mean, this is really the backbone of contemporary heart failure treatment. So this is the first drug that really reduced mortality, probably maybe ever in terms of a clinical trial, and validated this concept of the neurohormonal model, which is improving what our body's response is to heart failure is the real treatment paradigm. And so when you look at ARBs, they've never really taken off in heart failure, in part because the industry was never brave enough to do a head-to-head clinical trial. And so what they've done instead is to look at ARBs plus ACE inhibitors, which have shown some incremental improvements. So think about CANTOS and 4-year level improvement related to hospitalizations, but no reduction in mortality. And so where we do use ACEs and where there is good benefit is for if somebody is ACE intolerant, particularly because of cough. And so ARNIs, when you look at that, are really just incremental improvement in mortality and heart failure outcomes. So the claim to fame would be, that there's benefit compared to that, and we could potentially, reduce your diuretic dose. It does seem to result in more natriuresis and diuresis. There's 2 drugs in 1 tablet. That's maybe exciting if you're a patient. And then the clinical trial experience with ACEs is also really strong. I mean, we have hundreds of thousands of patients and many years of study. We know everything there is to know about them. ARBs have not been as broadly studied, but it really have some significant trials. And I've talked about they've never really done this head-to-head study versus ACE inhibitors. And then with ARNIs, we really only have this singular clinical trial. So we're a little bit as unclear, and particularly think about our world, which is decompensated heart failure patients. We don't really have the comfort level in knowing that this results in more symptomatic hypotension. We're a little bit more leery. And I'll tell you, from heart failure, from a literature perspective, what you do in the hospital echoes like completely out into the community. So if we don't start things here, they tend not to happen as robustly as one would think. And so adverse effects, so we know about the dang cough with ACE inhibitors, as patients like to call it, rare risk of angioedema, and then ARBs, basically the same with no cough, but virtually the same as ACE inhibitors, and again, ARNIs, no cough, but more hypotension. The tablet color is also, ACEs are boring at this point. The colors are generic and boring. ARBs have very seasonal varietals, so they're like kind of a nice, like bold colors. And ARNIs, they've gone with pleasing pastels, so they're very, more interesting to look at. But really, the reason why I think the traction hasn't been as robust here is ACEs are completely everywhere. I mean, we have the Walmart $4 list blanketed with pretty much 3 or 4 different ACE inhibitors. ARBs are generic, but I came up with this phrase, generic but not ubiquitous. So meaning they're kind of falling in that price mark that is just enough that would be that makes us think twice about them in patients who don't have insurance because they're in that kind of $50 to $100 a month range. But where ARNIs have come in with the pricing structure is about $500 a month, and so that's the AUP or AWP average, and that's really quite significant. So it makes us really pause when we think about how accessible ACE inhibitors are and the incremental benefit. It's not really a surprise to me that we would not have the most robust uptake with it. And if you look at Europe, for example, because of the negotiation and price structure there, these drugs cost about $150 a month over there. So it's a really significant difference. And I would say that there would be significantly less resistance if we had kind of a rational pricing structure. And so this actually led to the extremely unusual, I think, recommendation that came out of the 2017 ACC HFSA heart failure guidelines, where they actually put in a recommendation, and I've never seen this before, in patients with chronic symptomatic HFrEF, which is heart failure with reduced ejection fraction, who are symptomatic and who tolerate an ACE inhibitor. They actually recommend you switch them to an ARNI because of reduced morbidity and mortality, which isn't factually untrue. But I've never seen a guideline industry try to carry weight for pharmaceutical industry. It's sort of a very unusual thing to see. Yeah, you should actually go and switch these patients to ARNI. So it bothered me a little bit when I saw it because there's never been, I think, another analog where we've seen that kind of recommendation. And I can tell you that very likely that was put in because sales figures were not as robust as were hoped based on the outcomes with Paradigm. And so this kind of leads me to ramble for a minute about why drugs cost so much, and which I think is not really new to a lot of people, but I think everyone's aware of some of these issues. But basically, the drugs cost so much because our healthcare system allows manufacturers to essentially set their price. And there are differences when you look at other healthcare systems where they actually have criteria and will require a drug to meet quality-adjusted life year benefit. And so England and Wales I put here. So they require that drugs fall somewhere within a $25,000 to $40,000 per quality-adjusted life year. So it's a very specific target that drug therapy has to meet. We also allow market exclusivity with new drugs, in part for manufacturers to recoup their investment. We also are very insulated, I think, even as pharmacists, but certainly physicians are pretty insulated from the cost of therapy for a specific patient in therapy. I think we've gotten much more involved than I've ever seen in my practicing lifetime about assessing affordability for patients because of necessity. Whereas I can say, 10 years ago in my entry level into the profession, we were not as concerned or not as robust just because I think the cost has continued to ratchet up for many of these patients. I've always had the idea, and I probably should have patented it, but where I think you would look at least displaying, at least in some way, shape, or form to providers, whether it's like kind of number of dollar signs or something, the cost of actual therapies that are being prescribed, because I think otherwise everybody's just sort of, it's really easy to click this button in Epic or prescribe this prescription, but you really have no idea like kind of what that does in terms of the cost of the system. And so I think just awareness all around is an issue. We've also seen, competition has been an interesting thing within the pharmaceutical industry, where in some cases it actually has reduced prices. So Hep C therapies has been somewhere where we've actually seen some reduction in prices. There have been more therapies to market, but in other cases, when the market is big enough, and I'll use statins as an example, you've had multiple branded statins that have been sorry, my phone's going off, competing, but haven't really reduced in price because there was a big enough market, essentially, where they didn't have to compete with each other. Generic drug availability has actually been the one thing that has only consistently been shown from an evidence-based perspective to reduce prices, but often these are delayed, and there are a lot of tactics that industry uses to prevent that. And the other really big thing is that our public healthcare systems are prohibited by law from negotiating with manufacturers. So our biggest payer, Medicare or even in the state Medicaid, can't actually go to as a group to a manufacturer and negotiate a price. They're prohibited by law from doing that. And of course we know this has hit generic drugs as well. So this is the case with the albendazole-mebendazole issue where due to consolidation, there's been one manufacturer that's cornered the market and essentially has risen prices appropriately. Everyone heard about the EpiPen issue last year, and so the price under Mylan has skyrocketed based on the fact that they have no competition. And even on the inpatient side, we've seen a lot more of these examples. So nitroprusside and isoproterenol in my area used to be so affordable that we wouldn't think about it with using it, and we've seen cases with nitroprusside where we're actually, I've never thought I'd see the day where we would, shift towards calcium channel blockers just because they're really now more cost effective than nitroprusside. And this has actually resulted in, I'll talk a little bit what health systems can do, but there have been some big changes at places that are large users of these therapies because of this. And so if you look at this from the industry perspective, their goal is really to improve the health of the country. They're publicly funded companies, and so their goal is to return maximum value to shareholders. And when you look at their language that they speak in terms of sales, it's all about return to value to shareholders. And so their justification really is that this is a research and development issue, and they have to account for drugs that don't reach the market. And so there's been this number kind of floated about that it takes about $2.6 billion to develop any singular drug to market, and that's been bandied about. But it doesn't take into account the fact that the majority, or much, I would say, innovation, so whether it's the translational science that led to actually the identification of that molecule as even a potential target, or in some cases the molecule itself was developed through public partnerships. And think about the role the NIH plays in developing these drugs. But academic medical centers also do quite a bit of work. And so this is a figure that was released. So for those in the oncology side, Vinny Prasad, he's an oncologist, but basically has been railing for a couple of years about the cost of oncologic agents and cost effectiveness. But they did some research and actually looked at publicly reported figures and looked at what percentage of these were actually spent on R&D. And if you can see with Novartis, about 57 billion in sales annually, and only about 17% of their budget is dedicated to R&D. And then they published this analysis, which looked at the return based on the R&D costs, and this is really difficult to read, but basically this light shaded figure is their return on their investment versus the darker shaded is actually what their investment actually is within these molecules. So you can see in many cases when they really hit big on some of these things, and there isn't much incentive for them, I think, to pull back based on the fact that their goal is to really return value to the shareholder. So there are a lot of examples, and I brought up the CAR-T example in the beginning, and many may know this, but actually it was almost completely developed at Emory University. So there wasn't really a role of Novartis or a drug manufacturer in that until they essentially swooped in at the last minute. So R&D costs from that perspective, they didn't share any of that. So for them to come out with multi-$100,000 costs is completely hypocritical, I think. And so looking at what would improve the system, so there's a lot of these bandied about. A lot of it requires congressional action, which I think most of us are fairly cynical will occur, but limiting patent extensions is one thing. Policing anti-competitive practices like pay for delay, in which case we've actually had situations where manufacturers have paid a generic company not to release a generic product so that they could preserve sales. Allowing our biggest payers to actually negotiate with industry. And then things this has been a really interesting thought and one I like quite a bit, but actually drugs that are developed with public funding to actually charge a royalty fee to a manufacturer so that we could recoup that as a system. And then improving the availability of getting generic products to market, so enhancing the FDA ability to do that, but also biologics reform where there is a lot of money tied up in the manufacturing process that it's very difficult based on the laws and the way they're structured to allow biologics to be generic. And then from the state perspective, negotiation with Medicaid and then mandatory generic substitution. But from the local perspective, making your formulary value-based, we've talked about that a lot here, is incorporating things like cost effectiveness. And there have been a lot of health systems that have increasingly done this. So there's some good examples from Sloan Kettering where they have literally denied putting an oncologic product on formulary because they did not feel it was cost effective. I also am aware of the Cleveland Clinic essentially has switched using nitroprusside in heart failure patients in favor of alternative therapies. So those things are all, I think, important decisions. And then also making sure that we're providing the best evidence and cost effectiveness, and also enhancing cost transparency, because I think a lot of our frontline care practitioners are completely unaware of what drugs cost. In many cases, we are as well. So I also include this as the last one, which is a little bit of a joke, but which of the following would be the least effective intervention in reducing drug costs? So allowing government payers to negotiate manufacturer reimbursement, making formularies value-based, providing a free Amazon Prime subscription for your PCSK9 inhibitor, and limiting the ability to extend patent life for non-substantial advances. So clearly see, but watch that animation. So. All right. Anyway, I'm happy to take any questions. I've kept you a little bit, but if anyone has any thoughts or comments, I'd be happy to respond to them.
I think increasing transparency across the board, not only to the physician but to the consumer, would also help. I see these costs and drugs as even another form of taxation. And you can take the money from the people who have it and then give the drugs to the people who don't.
I agree. No, I think it's great. I don't know that from our perspective how much we're even aware of like the charges that go out from our institution. I think it's pretty. A lot of these things end up on social media where you go into the ED and you get Crofab or something and you get this charge where you're like, holy smokes, and you get $50 saline bags and these things that seem a little bit out of proportion to what even our costs are. But those things are put into place, because we're getting reimbursed essentially for a fraction of that, and so we're hoping to really just kind of like get anywhere close to what we're actually paying out for that.
Yeah, so. Nobody knows the cost of it.
And nobody knows.
Nobody knows.
Right.
Somebody's doing some calculations behind the scenes.
Danielle knows. Nothing. No.
So there is a resource, and I don't have the web address on the top of my head, but I can send it out if anyone's interested. There is an email address that you can email and ask for what is the charge for a procedure, a med, any type of like service, so that a patient can have that information before they agree to receive it.
That's good.
So that's available, but it's like the Patient Financial Services Department, and they share that information.
Very good.
Will that ever be incorporated into Epic? Like in old this system type things, you would have a charge cost to the side. Is that considered? Well, at least they give you maybe a ballpark, like whether or not it was.
It's in like it's behind the scenes, but I don't know if there is an effort to put that out to any frontline user, other than going through this email pathway. That's all I know.
I recommend the dollar sign system, but you'll have to pay me a royalty.
I think that was a choice in the original Epic build, but because it could change in a heartbeat, I don't think there was any aptitude for trying to manage that.
Yeah.
You know, the Yelp number dollar sign.
Oh, really?
Yeah. I mean, yeah, but there was just like, how would we ever manage that?
I could do it. Yes, Lindsay.
I don't have any, I'm not really that well versed in like some of the, this is an area that I think is really interesting, but I don't know a lot about, admittedly, but the rebate idea that you mentioned for the CAR T therapy in the beginning, is there any kind of precedent set in that industry for something like that for any other drugs?
They've tried to offer it. I think PCSK9s were the first that I've heard of that they have offered a rebate based on disease, which I think is an interesting idea, but at the end of the day, I think you have to look at it from, they're not going to do anything that is going to, I think, impact their ability to provide substantial return for them. So I think it's an interesting idea from the system perspective. If you could look at it, it still has to be set it still has to be priced where it makes sense. But I like the idea, and I think from a consumer perspective, I would like that. I would appreciate something like that as well. Particularly when you're talking about preventative drug therapy. To me, that's an adherence point as well. That that's always difficult to get across for prevention because patients never really feel symptomatic because of coronary disease. So we all are, I think, fairly adherent when we're infected with something, right? So we're going to take our, azithromycin to feel better and improve. But with coronary disease prevention, it's like you never feel any different. And so you're preventing this event, you may or may not be aware of what the experience is. And so anything that we could do to make that case to patients in terms of adherence, I think would be helpful. And I think the other, so the Cantus, the latest thing, the anti-inflammatory is also the other thing I hadn't really heard of before, but it's actually potentially charging different prices depending on indication. So keeping this fairly exorbitant cost for orphan drugs, which I appreciate because there's cost that goes into development for a fairly small number of users for those acronyms that I no longer remember. But when you talk about a broader indication, then maybe they could set a different price when you talk about a much bigger market and something that would kind of make some sense. So, yes, ma'am.
So, playing like devil's advocate, how much do you think those companies have to pay for legal fees associated with the
Yeah.
and all that?
Yeah, and that was I showed you the number with the graphs with the oncologic stuff, and so that was actually very broadly criticized by industry, and they did have a lot of points that I think there are a lot of costs that go into maintaining a drug, and so part of it is legal. There also are a lot of patent, things that are also legal but revolve around just the administrative side of maintaining a drug, and there are, of course, an incredible number of regulations surrounding the actual manufacturing of the drugs themselves. And so there probably are more costs than we appreciate, but the point is nobody is transparent about what they are. And so this was actually somebody's only attempt to just try to make 1 + 1 = 2 with this, because otherwise we have no idea what their actual cost is within it. And in the case of CAR T, I think I think that one is very egregious to me, in that most of the development work on that was not, so basically their cost into that is essentially administrative, or acquisition for the actual use of the drug.
My uncle's a lawyer for Johnson & Johnson, and
Yeah.
he's losing like billion-dollar cases like once a week.
Yeah, and there are, and of course, if you follow the political debates, there's always the questions from, our legal system and how much does that actually cost the system. Physicians are very likely to point out, they do things that probably increase costs because they want to avoid lawsuits, and it's never really been easily quantified. I would just say that. Again, it's one of those things that probably needs to happen in terms of reforming what can and should be done with lawsuits around medications. But to me, it's like probably it's bigger than just that by itself. But I think that's certainly a piece of it. Thanks for being a double. All right, thank you.